Okay, it's 12:05. In the interest of time, I suggest we begin.
Sure. Good morning or good afternoon, everybody. Welcome to another session of the Pan American Trauma Society. I'm Roberto Calderon. I was appointed as a moderator for today. Today is presenting, we have Dr. Maria Fernanda Detanico. She's a trauma surgeon from Rio Grande do Sul, Brazil, and she's presenting a case titled pelvic gunshot wound. So, Dr. Detanico, can you share your slides, please? You can present the case, and
yes,
I will ask some assistants to give some opinions on your case. Everybody's welcome to participate, either raising the hand or writing in the chat. Please, Dr. Detanico, the panel is all yours.
Hi, hello everybody. Good afternoon. Good morning. Are you listening to me fine? Okay.
Yes.
Okay. So, okay, let's start. It was not a pelvic one. It was an epigastric one. It's okay. It's just a little bit different, but it is gonna be okay. So the case is por que não vai? This one, sorry. So this patient, she arrived at our hospital in August 24. She was a female, 25 years old, multiple gunshot in another city, distant more or less 40 minutes from here. What happened is that that she had that gunshot. She and her boyfriend. He was much more unstable at the first moment. This first hospital was not able to treat both of them in the same time. So they transfer her to our facility. That's I'm telling you, it's more or less 40 minutes. So the trauma happened more or less 1 hour and a half, maybe, before that she arrived at our hospital. She received 2.5 liters of finger and 1 unit of blood. She arrived more or less in our hospital at 4:55. It was a gunshot at epigastrium and some gunshots in the legs and thighs, nothing really important. And at the arrival, she was having this heart rate of 130, BP 100/74. The fast was positive for the abdomen, negative for the lungs. And it was already decided to go to the OT. This is more or less this first exam, and the decision to go, and she was in the OT, was 5:15 more or less. Any question? So
Fine, thank you. One question, Dr. Detanico. Do we have an exit wound or only the epigastric wound?
No, only one.
Okay, thank you.
Just some on the legs, really nothing important, like in the legs, even it was not something important. She made some x-rays, but more for the legs, and it was not important.
Okay, so thank you. We have in the panel, we have Dr. Kasim. Dr. Kasim, could you please make a comment in this case and your initial management? Good morning, sir.
Well, it says, good morning. It says multiple gunshot wound. And according to Dr. Maria, you are seeing only one bullet hole in the epigastrium, or did you see many?
No. At the abdomen, just one. The others were in the thigh and the leg.
Okay, I get it. Okay, I get it. Okay.
But it was so like
single bullet penetrating the abdominal cavity in the epigastrium, and the rest in other places of no importance. So I get it. Okay. Well, this patient obviously looks stable at this moment, but that's going to change very quickly. So FAST is positive. I would most likely will do a KUB and a chest X-ray because I want to see the trajectory of the bullet to see where it is lying, if there's no exit wound. And then, in my opinion, I would not go to the CT scanner with this patient because it is not going to add anything to my knowledge of what is happening to this patient. I think the patient needs to be, patient needs continued resuscitation and then taken to the operating room for immediate laparotomy without wasting time in the CT scanner. Thank you.
Thank you, Dr. Kasim. Can we have, please, Dr. Francisco Collet?
Yes, I think.
Hello.
Hello. Hi. I think this patient, you need to go, patient first. Can start with the protocol, massive transfusion protocol, specifically shock. I want to know if there is only a hole of the bullet on the anterior abdominal wall and the posterior region. There is no wall. So you have sometimes you have some bullets comes to the thigh or comes to the abdomen, but sometimes bullets in the thigh can go up to the abdomen. So I think you can start with an X-ray, a chest X-ray, abdominal X-ray, to see where is the bullet, to see what to think about. And this patient, you can go directly to the OR because there is specific shock. The patient have abdominal injury. You have fast exam, so this patient will not be needed to do CT scan. Sometimes some people go to make start hemodynamic reposition and then try to make a CT scan to find the injuries to make more safety surgery. I think sometimes the patients may be borderline, hemodynamic borderline, so they try to make a CT scan. But I think in these patients, you need it. You can go to the OR. Might start with massive transfusion protocol.
So they asked for blood for her. That's why I'm telling you, like when you realize like it was 20 minutes when she more or less when she arrived and decided to go to directly to the OT. We asked for blood. Normally you have here like oh my God, just forgot the name. We have the whole blood, but for her, I don't know if we have at the moment, but we asked it for blood units and fresh frozen plasma. Normally, we don't have here in our hospital platelets. They need to come from another facility that is just like maybe 1 or 2 blocks from here. So this takes some time. But they started with the tranexamic acid, calcium, all of this, but also in a way of keeping the hypotension not to increase the systolic blood pressure, because already the decision was to go to the OT to see what's going.
Thank you. So we all agree to start some transfusions, maybe an extra chest X-ray and abdominal X-ray, and take the patient to the operating room, avoiding the CT scan. This is in danger. One question, Dr. Detanico. You said the FAST was positive. Was it only in the abdomen? Yes. What about pericardium or pleural?
Only. Thorax was free. Yeah. Only in the abdomen there was free fluid, and the others. That's why they didn't ask for the X-ray, because. And she had also some abdominal signs. She was having some tenderness already. So that's the decision.
Okay, you understand. Can you please keep going with the case? Thank you.
Okay, let me just see if this one is working. No. I love this one. So more or less 5:25 a.m. She went to the laparotomy. She had a retroperitoneal hematoma in zone 1. She had a liver laceration grade 3, more or less in the segment 2. She had a duodenal laceration, grade 3, 75. The posterior and lateral wall of the tree, the simple suture. She had a vena cava lesion laceration, lateral laceration, and the bullet was inside the vena, the cava. Because of the huge heteroperitoneal hematoma, they were not so sure if there was also some mesenteric, also artery or vein damages. So they sutured something. That's exactly what they said. We could not see through the bleeding. Estimated blood loss more or less of 6 liters. Blood reposition at this time is 7 units of blood and 7 units of fresh frozen plasma, and asked for the platelets to come from the other hospital. And she went to the ICU more or less 7 and 8 a.m. They just sutured the skin. That was the damage control that they did. No Barker dressing. No Barker dressing at this moment.
I understand. Do you have any Aftera or in your hospital?
No.
I'm only asking, not judging.
No.
Okay.
We just have even later we just have the Barker dressing. We don't have even the commercial ones.
Okay, understood. So can please Dr. Colette comment in this situation in the operating theater about the findings and the procedure done?
Treatment is patient. If the patient go
I
to
can
the
listen.
you can take
Sorry, Dr. Colette, can you talk? For me, it's really bad to listen to you. Can you talk a little bit closer to the microphone,
louder,
please?
a little bit louder.
And also, yeah.
Can you listen more now?
Yes.
Yes, it's better. Yeah.
Okay. I think this patient will go to the OR. You have to find the hematomas on one, liver laceration, packing, duodenal lacerations. Of course, if there is no injuries of the papilla or not the pancreas in this situation, you can maybe done a simple suture, usually, and the lateral wall of the vena cava can, if infrarenal vena cava, you can maybe suture or can maybe tie it. Sometimes you can be tie the vena cava above the vena renal. And superior mesenteric vein is a problem, very big problem. If there is injuries of the superior mesenteric vein, sometimes very difficult to repair. Tie superior vena cava, superior mesenteric vein is very difficult, so you can try to repair. Sometimes the repair impact because the ball may become swelling and maybe heavy. And then when you see the vena, the inferior vena, mesenteric superior vena, maybe stenosis of this vein, and sometimes maybe thrombosis of the vein. Sometimes very complicated injuries in this situation. I think it can stop, try to fix it, and then stop and make a damage control surgery, and then review the surgery the next 24 or 48 hours later. Okay.
Sorry.
Your microphone.
Yes, Dr. Maria, what were you going to say?
No, your microphone was off. That's why.
Okay. Thank you, Dr. Colette, for your comment. What about Dr. Kasim? What do you think about this case?
Well, interesting finding. Of all the things Dr. Maria has told us, what is the first thing that I would do? I would definitely go after removing the bullet, because if that bullet goes into the heart, that's another operation. I don't want to do that. I want to avoid that. Pick up the bullet and suture the infravena cava, lateral sutures or horizontal sutures, whichever that is convenient for you. But don't spend too much time. Get that done. Second, stop the bleed from the superior mesenteric vein. The simplest thing to do there is ligate it, because literature shows ligation of the superior mesenteric vein is well tolerated, and if there is mortality, it is much less than doing interposition graft or anything like that. Don't spend too much time, just ligate it. Then go ahead and repair the duodenum with a simple suture, and then pack the liver. Then comes the major part. What should you do with the retroperitoneal hematoma in zone 1? I, for one, do not like to be an ostrich. I don't like to bury my head in the sand and walk away. I will do a catal and a brash and a Madax manure. I will mobilize everything in that area so I can get a good look at the zone 1 hematoma and address to see if I can stop whatever is causing the hematoma from bleeding. Because if I don't do this now, I probably will have to come back very quickly from ICU to do this. And I would like to get this done while I am in the operating room, and then think about taking the patient to ICU after that. In other words, I will not ignore it. I will go for it right now.
But I think it was like this huge hematoma was from the vena cava. That's why, and they were in the middle of this hematoma, so that's why I put all of this, because they were not so sure if there was or there not some lesion at the mesenteric vein. It was not clear, because what it was like, a lot of bleeding, and the bullet inside the cava, what they remove and they suture the cava. So some other bleeding points, and they suture and ligated, was not so sure because it was in the middle of this hematoma. But one thing that was for sure, that there was another a big lesion like aortic. Maybe it was only in the vena cava. It was the main one. And
in that case, I would just repair that. And if it is not in the true zone 1 position, I would not go and poke the bear. I would not do that. Thank you.
Exactly. And let me point.
Yes, thank you, Dr. Maria and Dr. Kasim, for the pearls. So I understand that the aorta looked fine and the pancreas didn't have any injury, I think.
The pancreas, to be honest, they put in the description, it was not me who did the first one, but it was me who did a lot of the sequence after the surgeries. And just like to remember, like it was more or less this one, what happens. Like it took the lateral posterior wall of duodenum, just reminding, it was more or less like this, what happens. And but after that, they put some maybe pancreas. I think it was more something, but not like the head of the pancreas. It was not from the organ, but something in the periphery of the pancreas, but not after the review. That's what I saw. And this is just to remind, like this. Now you have the vena cava here, and it was really close. But kidney and other things, it was okay. It was pretty much okay.
Okay, keep going, please, Dr. Maria.
Keep going? Okay.
Yes.
So then she went to the ICU, more or less 3 p.m. They called again the surgical team to re-evaluate. She was in high doses of noradrenaline and vasopressin. Mm-hmm. This was 75. I don't know how, because this is concentrated here. We used to say that it's 8. Oh my God. It was a high concentration of this and vasopressin. She's still like having some signs of a shock, and lactato was high. This was the gasometry, and so at this point they decide to reopen the abdomen to see what was going on, if there is some bleeding. I don't know if we What do you think it could be? It could happen now.
Would you like to answer, Dr. Colette?
I asked for all of them.
Oh, I think the great problem here, because you can see the dressing of the abdomen. There's bleeding in the dressing of the abdomen, or not?
Some fluids, but
because when you make a temperature control to review the cavity 3 hours after, usually you can see bleeding from the abdominal dressing. If not, you can wait. Sometimes because the patients have a pH normal, bicarbonate normal, XSS normal. The patients may have other injuries that can maybe advise all inflammatory procedures in this situation. But it can review. But usually I go to review in these situations only when the patient can blend in a lot of the peritoneal stomach. So I think at the moment can wait, but sometimes something is missing. So I can go to review, but it's not by this finding here. I think it's going to wait. Can wait, but I don't see the patients at the moment. With these signs, the patients are in shock, of course, but the lactate is not too high, and the blood gas is very, very normal. And you said that you don't see bleeding come from the abdominal dressing, so the peritoneal stomach. So I think it can wait.
Thank you, Dr. Colette. Dr. Kasim, please.
This is a 26-year-old lady, and she is post-op in ICU, and she's being maintained on a reasonably high dose of norepinephrine and epinephrine, or whatever it is they're using. In other words, she's on vasotonics, and I don't know what the blood pressure is doing, but the heart rate is.
This is the
blood pressure is low, 62. Heart rate is high, blood pressure is low, high dose of vasopressin, lactate is reasonably high, even though the blood gases does not show a great deal of base excess negative. I think this lady is bleeding. I think she needs to go to the operating room and to be reevaluated. That's what I would do.
Okay, thank you, Dr. Kasim. So, Dr. Maria, was the patient taken back to the operating room, or what did you do?
Yes, she was back. So, neolaparotomy, she had a ischemic right column, and the ilium, distal ilium, was more or less 1 meter was ischemic. So, because probably what they thought is it's some of the ligations and sutures and whatever they did at the first moment to stop the bleeding, or even some clot maybe come through because this really seems like a branch from the right colic. So that's why they decided resection, no anastomosis, packing again on the liver, no bleeding. The suture of the cava was okay, no more bleeding, and Barker dressing now. This is what happened.
Does anybody want to comment, Dr. Kasim?
I think it's the right thing to do. If you have an ischemic bowel, resect it, and for God's sake, don't do an anastomosis. She's hypotensive to begin with, and you've done if any type of anastomosis will be catastrophic for this patient. And if there is any packing to be done, pack it, and get the patient off the table quickly, and then take her back for further resuscitation in the ICU. I think you did. This is exactly what I would have done, and let's see what happens.
Yeah, thank you, Dr. Colette. Any other comment?
Yes, my comment is like this. You can see by these findings, there is no bleeding. You have ischemia of the colon and the distal ilium. So maybe I think it's a arterial ischemia or venous ischemia, because when you have injury of the mesenteric vein, you can maybe injuries, maybe some venous injuries, not, and maybe sometimes you can. It's very early to see sepsis by this in this situation, but it's not common. So I think this patient it was correct to do no resection and packing, no anastomosis. But I think the great problem sometimes may be evaluation by this, because when you have injury of the mesenteric vein, sometimes what happens is venous ischemia by thrombosis, mesenteric venous thrombosis with ischemia of the colon and the. So I think it's a great problem.
Yes, thank you, Dr. Casim and Dr. Colette for the comments. So, Dr. Maria, what did you do right after this second operation?
So this was more or less 12 hours since the arrival from the first time that she arrived at the hospital. So she went back to the ICU and pretty much the same. It was the same. The norepinephrine going down, it was 75 and now 57. Still the vasopressin a little bit better, but we know that she just passed from another surgery. So in the 26th, so she was pretty much now, it was like 36 hours, more or less 30 hours after the first arrival in the hospital. She was in the ICU. She was still really bad. And now it was the discussion if she was still ischemic or not, if there is any part of the bowel that it was ischemic or not. And even because it was, was the problem, it was starting to a little talk about should we keep investing in this patient or not? And in all of this kind of math, so I decided to another laparotomy. This time I did inside the ICU, just to review, nothing else, just to see how was the rest of the bowel, the intestine, if it was okay or not, if there is any other segment that it was ischemic or not, and also if it was a complete small bowel ischemia, we are going to stop. That was the point. So we reopened the patient again. We saw like really enlarged, like with a lot of edema in the small bowel, but with peristalsis, with not a great color. It was not that little rosé. It was a little bit purple, all of the small bowel, but all of them with peristalsis. So the decision was to just put 2 packings to compress in the liver, that it was still having some bleeding from there, and remove some other compress and suture the skin, and now plan that we're gonna keep doing everything that this patient need, blood, whatever she need. And the plan is for the next 24, 48 hours, and then go back to the OT and to probably if it was okay for the anastomosis.
I understand. So this was like a second look operation for ischemia of the bowel.
For ischemia, yeah. It was the decision for the ischemia, because it was not so sure what happened that caused the first ischemia. So it was kind of maybe because she was not good. She was still 20 with no signs of bleeding, but still with high lactato, the needing some medication for the blood pressure, and to see if something that we can do, maybe remove another part of the bowel, or maybe to say that we have nothing else to do. Maybe if it was all ischemic, as we don't have here the multiple organ transplantation, then we're gonna be in a chaos, a really bad scenario.
Okay, I understand. So you didn't find any more ischemia, or
no?
So the patient was taken back to the operating room in 1 or 2 more days. So I think we can keep going with the case.
So, so in the 27th, that this was the day. So she was with just one. This was the dose of the noradrenaline. That remember that we went to 75 from the same, and the medial blood pressure was 80. The heart rate was really normal. So she was all the rest of the exams, the blood exams, they were pretty good. So we decided that it was okay to put her in another surgery. So this was the 27th. So we did the ileocolon anastomosis, lateral lateral. We did a cholecystectomy because the gallbladder was ischemic. We reviewed the duodenal, it was okay. The suture, nothing, no leakage. The vena cava also was okay. No other signs of bleeding. And we put again a Barker dressing with not a fascial closure, but with approximation of the abdominal wall. It was not possible to close in this time, was a little bit distended. And that's why we did plan it. And we put a drain in the heteroperitoneal under the duodenum.
Okay, so we can ask our panelists about comment. Please, Dr. Kasim, what do you think so far about the case? Would you do the anastomosis with that tiny dose of vasopressors, or would you wait a couple of more days? What do you think?
Personally, I would not have done an anastomosis because the risk of this anastomosis breaking down is much higher than healing. And cholecystectomy, questionable. If it is ischemic, yes, I think I would do a cholecystectomy. And now this patient has a typical, the third space swollen bowel syndrome. And unless you know how to take care of it, she's going to get compartment syndrome and all the other sequelae from that. So it's a very difficult situation in a patient who is at 3 operation or 4 operation. I'm not sure. I think I can count 3.
This is the 4th.
4 operation. Yeah. And every time you go into the abdomen, it becomes more and more hostile to you, and it doesn't serve the patient very well. So in the long run, some of the things that the surgeon did probably was necessary, such as the cholecystectomy, because he's the final judge. He looks at the gallbladder, he thinks it's ischemic, he needs to remove it, period. And anastomosis, it's a personal choice. If the surgeon thinks that the environment looks good, go, and he wants to do an anastomosis. And then if it breaks down, he will be blamed for that. But I think to play it safe, there's no hurry in doing an anastomosis. Why do an anastomosis that might break down? Why not wait a little bit longer when it will not break down for sure? It'll heal better. So I think it is a judgment call, and the experience comes from judgment. Judgment comes from experience. Thank you.
Thank you to you, Dr. Kasim. Dr. Colette, what do you think about? Do you agree with the procedure done, or would you propose any other choice?
I think in this situation, first, I don't know why it's ischemic of the colon and the ileum, and the gallbladder too. So I think in this situation, I can see the ball. If there is edema on the ball, I think maybe come more venous or thrombosis or venous insufficiency portal can become with this. So sometimes it may be difficult to make anastomosis in this situation. I think this patient may become more stable in these situations. Before this surgery, I think these patients may be helpful to make an angio-CT of the abdominal vessels and see what's happening, to try what to do, and to find if there is some thrombosis, something very different can be avoid anastomosis. So I think it's very important. When you have injuries of the mesenteric vein, you have pancreatic injuries too. Sometimes patients have some pancreatitis near where's the bullet or the duodenal in these situations. Sometimes it's important to know this and to avoid anastomosis. I think I don't close the fascia in this situation, true, because I think they become more, if there's edema on the ball, and sometimes the patient may become a compartmental syndrome. So I stay with patients open. Maybe some small stitch of the aponeurosis, and not close the aponeurosis. Put only stitch, and then try to approach, but avoid to close the facial approximation, total approximation, and avoid. Sometimes maybe can go, maybe go okay, but usually I prefer this. I think these patients will have sometimes maybe important decision and what to do if you have a CT before the surgery. But you can do only C, and maybe do the operation maybe a correct option too.
Just to inform, as I saw the small bowel on this was on a Wednesday. I saw it on Monday and I saw it on Wednesday. They were completely different already. Even it was a little bit enlarged, not too much. A lot of ileal, of course, but it was looking good. It was completely different that we had on Monday. That it was that I'm telling you, it was not like necrotic, but it was like that purple, not good. Maybe it's difficult sometimes to put on words what we see, what I saw, but I imagine that you as a surgeon, you know that color that you don't think like it's good, but it's not also, oh, we need to resect, to do a resection. And at this point, no, it was good. Really, the abdominal wall was good. That's the decision for the anastomosis. That's why the plan already. Young patient, 25 years old, no other pathologies, no other. It was really something acute, and that she recovered. And the pancreas was pretty much okay also, with no signs of pancreatitis, no.
Dr. Maria, we have a question from Dr. Yoshiro Kobe from Tokyo. He's asking, what do you think that may cause the right column ischemia for the second operation?
So, like for the anatomy, if you really go for that, it was the iliobisecal, maybe that what some embolus, maybe. I was not so sure, because as I was not in the first one, because when you go like what they resect, it was the distal ileum with the right column. So that's in my opinion, maybe in that middle of something they put some stitches on that artery, not in the vein. That's my point.
Okay, thank you. Can we keep going with the case? What happened next?
So what happened next, that she didn't, the problem is that she doesn't like surgeries, because normally she go in high, she do a huge inflammatory response. That's why she was not okay. And the night of the procedure, but in the morning it was pretty much, now she was good. So 3 days later, they went again to the OT, now for the abdominal closure. It was pretty much okay. The anastomosis was okay. The duodenal also was okay. They kept the drain, no more bleeding, nothing, and even it was not so tense. They were able to do the abdominal closure, the final abdominal closure. Any question?
Dr. Kasim? Any question for Dr. Maria?
And another thing, we just put an asenteric tube for feeding on the other surgery. We put the nasenteric tube for food, for feeding. So we started as
that's great.
the nasenteric on the right for starting the feeding as soon as possible. As soon as she recovered, we started.
Okay, Dr. Kasim, do you have any other comment or question for Dr. Maria?
No, I think you saved the patient's life. It's important. You know, that's what this is all about, to save a life. And you didn't give her you didn't give her short gut syndrome. You know, you did very well. You saved the patient's life, and that is remarkable. Thank you.
Just
Dr.
wait.
Paulette,
I still have some more days for her inside
okay.
the hospital.
Well, at this moment, she's still alive, and you know,
yeah.
you're doing the right thing. You know, you made sure you get a feeding tube in somewhere. I don't know exactly, in the jejunum or in the ileum. Or
Jejunum.
I think hopefully jejunum. Yeah.
Mm-hmm.
And you'll start feeding her, and let's see what happens. You know, she might get better in spite of all the assault she has gone through. First gunshot wound and 4 surgeries, and she's still alive and doing well. 5 surgeries. She's still alive and doing well. That is remarkable. I think you're doing very well. Keep going.
Yes, Dr. Colette, any comments?
I think it's very important case because you can see the evolution of the patient. But I think it's more important, you can see Maria do our best when we beside the patient all the time. An indication of the surgery as you think you need. So it's very important decision. It's very important to know the people that when you have a trauma patient, you can stay beside the patient. And everything you can see, you can maybe take another surgery or can make another therapy as soon as possible, avoid too late. So congratulations for the presentation and congratulations because you can be beside the patient. Sometimes you can see the surgeons not become beside the patients. Thank you.
Thank you, Dr. Colette. Dr. Maria, one question. Just in case we need more days of bowel discontinuity or the patient makes a postoperatory ileus, do you have the availability of parenteral nutrition in your hospital?
Yes, it was as soon also she was hemodynamically stable. We started the TPN also with the feeding tube to have both of them in the same time. As long as because we are not so, because again we have two anastomosis is complicated. We have the duodenal, and that's why it was a feeding tube gist of this one, and we have also the ileal colon anastomosis. So also this was a problem.
Yes, that's very helpful for the healing of the bowel. Do you have any more slides?
Much more. I will just a little bit, because this was just the beginning. And 4 days after she started with a biliary drainage through the incision, she had a drain that it was not working. And we have the abdominal, now we have abdominal CT with lots of free fluid. And she went again to a laparotomy. I prefer not comment what happened here because it was a huge mess. And I prefer not comment what they put because this is nothing what happened. And they just put some compress and they said that it was one leakage, that it was not. So it was not me who did this one. And then I come back to the hospital on the September 5. So I put her again in another, now we are going to the 7 laparotomy. And it was a huge duodenal leakage with a lot of bile coming out. We could see that it was not in the papilla. Because she was having this large amount of bile. And I was a little bit scared if there is some bile duct, the choledicle was injured, but we could see it was completely open, the duodenum. So what I did, I put a care inside, did some sutures that I know that it was not going to work so very well, just doing, and put another drainage, also another drain under this duodenal, just to try to put everything from outside, to avoid the abdominal cavity and trying to close it as soon as we can to protect the bowel also, but trying to drain everything of this. And again, a Barker dressing. And then what happened? I would just keep going.
Yes.
And then from September 6th to 3 October, this was my vacation. I do the daily routine here in the hospital. She had a lot of dressings, the vacuum dressing, and they were just changing. They were not doing nothing. And then I just closed the skin because everything was, the cavity was okay. It was really a blockage. We cannot touch anything. We cannot even see anything very well. And she had more or less of this, like the 1,500 biliary drainage from the care of both of them and the right flank. She had also another drain from the left. It was under anastomosis because some of them said that it was a pancreatic leakage that it was never confirmed. And after all of this, just remember that she arrived in August 24, and she spent 2 months inside an ICU. I would just keep going. So on this 27 October, I closed the care because now it was really less. The drainage was slowing every day, and it was more or less 100 plus in the right drain 7. It was nothing. And we started the oral diet for her, liquids to Joyce, and started to see what's going to happen from the duodenal.
Excuse me, Dr. Maria. I'm sorry for the interruption, but we have to explain. Believe it or not, there are many people who don't know what a care drain is. We have to explain.
Oh, sorry.
Tube. See, yes, there are many people who don't know what a care means. That's what.
Care is the T tube. Normally we use for the biliary,
the common bile.
The common bile, exactly.
Common bile.
Yeah.
Keep going, please, Dr. Maria. I'm sorry.
Sorry. It's for us. If you ask for the T tube, we don't have. If you ask for care, we have a lot of. So I just put it to doing a duodenostomy and to put some flow on the drainage that I know that the suture is not going to work, and put also some stitches. It was not possible at all. If somebody asked it to do an ostomy, it was already, and she was a little bit fat. So also we could not bring it to the abdominal wall also. It was not safe to do that. It was not close. So this is October 22, she was discharged from the ICU. So it was inside our nursery. We closed the care and opened. It was really low drainage, and it started with, she was already having some water for just water. And we started now diet for her, just waiting to see what's going to happen. And this was 27. And on October 31, Halloween, she's starting to, this was the dressing. She was having some leakage here that it really looks like enteric, but from the anastomosis, the ileocolon anastomosis. So we stepped back a little bit, restarted new perorus, nothing by mouth, and full parenteral nutrition. Again, we are going down, and then we need to step back and restart. And after 1 week, I don't know what happened here, to be honest, why she leaked after 2 months. We started the liquids again, she was not accepting a lot. But I think it was some gastroparesis also, paralysis, it was not okay. But then in November 14, we removed the parenteral nutrition and she had full diet. And 4 days later, we discharged her from the hospital. So basically what we have for her, these complications, we have fistula, we have like long time parenteral nutrition. She had hemodialysis also. She had a thrombosis, venous deep thrombosis. She had a lot of infections with a lot of antibiotics, Subacter, linezolida, polymyxina, I have no idea if all of them. And that's what she had with almost 90 days inside a hospital with 13 surgical procedures. Just to not that these trauma patients, they are not easy. They are not for a simple hospital. That's why I have to say, but she's okay. She's already come back for a consultation and she's pretty fine. And we just keep looking for her for sometimes after we have now a huge hernia to correct, but not for the next months. We're gonna wait and postpone a little bit longer.
Excellent case, Dr. Maria. Thank you. So we spoke about penetrating abdominal trauma. We spoke about bowel ischemia, bowel failure. So interesting case. Thank you. Dr. Kasim, any final comments or question for Dr. Maria?
This is what's called the case from hell. When I was a chief resident at the University of British Columbia in Vancouver, BC, I had a case like this and took care of the patient for almost 3 months, just like you. And when she came back, she had a big hernia. She walked into the clinic and she looked at me and she took her right hand and slapped me. She said, "Look, you gave me a hernia." And that's all I remember. I saved her life, but she didn't care. But the hernia was the problem for her. You did a wonderful job in taking care of this patient. You didn't give up and you kept her alive and you saved her life. And that is what matters the most. I think I must congratulate you for your patience and your dedication and everything you had, you gave the patient to keep the life going for a young lady like that. She was what, 26 years old? 26, right?
Yeah.
26. Yeah. She will remember. She will thank you secretly.
No,
Thank
she
you,
was
Dr.
okay.
Kasim.
She was even with all of this. When it's the really hard part is when she was awake. She was talking to us. When you need to step back because of that fistula that came like 2 months later, and we need to say now we need to step back. We need to restart. And she was like a little bit sad, but she was okay. She was okay with the whole team, the nurses, the physiotherapy, all of them. This was something good. And the family was present all the time. So we are always talking and saying what the complications, what's gonna happen and what's the plan. It's always a straight conversation. This is something also that I think that it's really important.
So the case was from hell, but the surgeon was from heaven, Dr. Kasim.
Yes,
Yeah.
that is correct.
Yes. We have a question from Dr. Yoshiro Kobe, Dr. Maria. Did you put any percutaneous drainage for the fistula or any percutaneous procedure?
No, it was not needed because we put all on the surgeries. So that's why we put under the direct vision, and they work at all the drains. They work at.
No needed. Okay, thank you, Dr. Maria. Unfortunately, Dr. Colette had already to leave. I think we are already done with the case. I want to say thank you to Dr. Maria Detanico for presenting such wonderful case. And I want to thank Dr. Kasim and Dr. Colette for always their wise comments. Okay, Kevin, anything else to add?
I put the CME information in the chat.
Yes, we
Yep.
see it. Thank you.
So no, that's it. Thank you, everybody.
Yes, thank you, everybody.
Thank
Have
you.
a great day. We'll meet next week, next Monday. Bye.
Thank you. Bye-bye.